Well, good morning, good afternoon, good evening. I want to thank all of you for joining us today to hear about the Global Report on WASH and Healthcare Facilities. I'm going to hand it over to our moderator, Kellyanne Naylor, in just a moment, but just a few housekeeping rules. So first of all, there is a chat. It is being moderated. So if you have a question, feel free to ask your question in that chat. The second is, it seems some of you have the wrong link, the speaker link. We will be resending the participant link so you can log in and watch this through the YouTube channel. And lastly, the slides are already online at washandhcf.org, so you can find the slides there. So without further ado, I'll hand it over to Kellyanne Naylor. Thank you.
Thanks so much, Maggie, and thanks to all of you for joining us this morning, afternoon, and evening. As Maggie said, my name is Kellyanne Naylor, and I'm UNICEF's Associate Director for Water, Sanitation, and Hygiene. And on behalf of UNICEF and WHO teams, we warmly welcome you to the launch of the Global Progress Report on WASH and Healthcare Facilities, Fundamentals First. And I know this is a very, very busy time of year. It's late for some of you who are joining today from other time zones, but it's a chance for all of us to come together to talk about something that matters very much to all of us: water, sanitation, and hygiene, or WASH, in healthcare facilities. I think it goes without saying that the current COVID-19 pandemic has shown a spotlight on this issue and made it globally relevant and timely. As you may have seen in the press release for this event, WHO's Director General, Dr. Tedros, likened working in healthcare facilities without water, sanitation, and hygiene is akin to sending nurses and doctors to work without personal protective equipment. And UNICEF's Executive Director, Edie Force, said today that making sure we are sending children and mothers to places of care equipped with water, sanitation, and hygiene services is not merely something we can and should do, it's an absolute must. And I think all of us who are here know that WASH and healthcare facilities contributes to so many benefits, whether it's newborn survival, maternal and child care, infection prevention control, AMR prevention, the list goes on and on. I was feeling a bit nostalgic coming here today because some of you who have been on this journey with us will recall that it's been just over 5 years since we launched the first landscape report on WASH and healthcare facilities in 54 countries. This report that was released in 2015, I remember this well. It was during the West Africa Ebola outbreak. Pardon, j'entends la traduction en français. Oh, okay. Sorry, I'll try to continue. This report brought much needed attention to the dire gaps and made the basics like water, sanitation, and hygiene absolute essential prerequisite to stop the spread of infections to frontline healthcare workers. But it was really in 2018 when global action was ignited, when the UN Secretary General launched a call to action for governments, the United Nations, and partners to accelerate progress and improve WASH services in healthcare facilities. It was following this call to action that we were able to really set targets to look at reaching 100% of healthcare facilities by 2030. Since then, you may have known we've launched the first global baseline report in 2019, along with the 8 practical steps for universal WASH access. And shortly after, in May 2019, was the World Health Assembly, in which member states endorsed a resolution to improve WASH services, where countries made national commitments. And we know that this is where action and impact are at the country level. So this report and this webinar today comes at a very critical time. The world is faced with yet another disease outbreaks, estimated 72 million cases and 1.6 million deaths, profoundly affecting the whole world. So this report that you'll see that's going to be presented today We'll outline some of these areas where we still have gaps. It'll present solutions, real world examples from dozens of countries. And for the very first time, we're going one step further to share a price tag for the cost of WASH in healthcare facilities. While we continue to need political commitment to prioritize WASH in healthcare facilities, we also need the resources mobilized to achieve it. So this report coincides with an important day, which of course is the 2020 International Universal Health Coverage Day, with the theme of Protect Everyone. And we know that without WASH, the goal of ensuring all people everywhere are protected and get the quality of healthcare they need would not be achievable. And this is, of course, also, as many of you know, one of the core prescriptions of the WHO manifesto for a healthy green recovery from the COVID-19 pandemic. So while this COVID-19 pandemic has caused unforgettable damage in all aspects of our lives, let us tap the opportunities and the moment that is before us now to ensure that as we move forward into the future, every mother, every newborn, every child, and everyone receives healthcare in facilities that have adequate and safe WASH services. On my own behalf, on behalf of UNICEF, WHO, and the United Nations, let me seize this opportunity to ensure governments and our partners of our full support and commitment. I want to sincerely thank the dozens of organizations and governments and literally hundreds of people from around the world that have contributed valuable data and information to this report. What you're about to see here today, folks, is truly a collective effort. I also really want to recognize the WHO and UNICEF teams that have been working tirelessly behind the scenes, and my counterpart, Bruce Gordon, who have worked hand in hand in full cooperation to make this moment a reality. So it's my sincere hope that you who are here with us today will be able to use the information contained in this report to contribute to global, regional, national, subnational, facility level efforts to accelerate improvements in WASH in healthcare facilities. So I wish you all fruitful deliberations today. This is an important issue that concerns us all. It's urgent, and the time to act is now. So thank you very much. And before turning over for the presentation of the findings and recommendations to Dr. Rick Johnson and Dr. Maggie Montgomery from the WHO WASH team, I'm now pleased to turn over to Mary Koberi, a midwife from Malawi, who is going to speak to us about her experience as a frontline health worker to improve WASH and infection prevention control services and offer her thoughts on what more is needed from government and international partners. Now over to Mary.
Kupezeka kwa mazindu ukhondo kwatipangisa ife ngati ogwira ntchito pa chipatala pano kuti tikhale ochilimika pa ntchito yathu chifukwa chonena kuti zimenezi ukhondowo ndi madziwo atipangisa kunena kuti ife tisakhale nawo matenda oyambisa coronavirus. Komanso ifeyo tili wotetezeka, komanso kwa anthu amene amabwera panopa timatengera ndondomeko yake monga ngati social distance, cholinga kuti iwo asapasirane pamene ali kudikirira chithandizo, ifenso tisatenge matendawo. Ndeza tithandiza ubwino kuti tife unyadira, komanso pa chipatala pano alibe amene anapezeka nawo kachilombo kachani ka corona kuyambisa matendawo a COVID-19. Ndiye tili onyadira kuti zili bwino chifukwa chonena kuti tathandizika ukhondo ndi madzi atithandiza kutiteteza matenda a coronavirus. Tithandizo chimene tikuchisowa ife pa chipatala cha Mangamba ndi mastafu makamaka manesi. Manesi tilipo ochepa, anamwino umasa azamba. Makamaka tumakhala kunena kuti tikumalephera kuti tithandize patient moyenerera pena chifukwa chonena kuti timakhala kuti tatopa.
Hi, actually, this is Rick. I think I'm going to take it from here. Thanks, Kelly, for that great introduction, and to Mary for the inspiring video. It's a really good introduction to this new global progress report about WASH in healthcare facilities, and acknowledging that these kinds of services are fundamental to delivering safe health services, and they can no longer be overlooked. My name is Rick Johnston, and I manage the WHO side of the WHO-UNICEF Joint Monitoring Program for Water Supply, Sanitation, and Hygiene, or the JMP. Let's see, and click, please. Okay, so along with my colleague Maggie Montgomery, the lead author of the report, I'm going to introduce this report, starting with an overview of the latest data on WASH in healthcare facilities. And then Maggie will talk about the actions that countries are taking to improve WASH in healthcare facilities and what the main recommendations of the report are. The report is divided into 7 main chapters, and there are also 7 annexes with more detailed information. You can see the chapter topics here, and these represent contributions from around 100 authors and reviewers from both the WASH and the health sectors. I'll be mainly talking about chapter 3 with the data update on WASH services, and then Maggie will share some of the good examples from countries and regions in improving WASH in healthcare facilities. She'll also describe an early financial analysis about how much it would cost to achieve universal basic WASH in healthcare facilities, and then share 4 recommendations that make part of a renewed call to action. Okay, part 1 on the data. These are produced and regularly updated by WHO and UNICEF through the Joint Monitoring Program. We produced our first baseline report on WASH in healthcare facilities in 2019 and have now contributed a chapter to this 2020 update report. We will be updating the global database every 2 years, along with the databases on WASH in schools and WASH in households. And here on the screen, you can see some of the main messages about healthcare facilities in least developed countries, which have some of the most vulnerable health systems in the world. 70% of healthcare facilities in least developed countries lack basic healthcare waste management services, half lack basic water services, and 20% have no sanitation services at all. I want to start by explaining a bit where those numbers come from. When we speak of WASH in healthcare facilities, we're talking about 5 distinct service areas: water, sanitation, hand hygiene, healthcare waste management, and environmental cleaning. For each of those service areas, we have defined what a basic service level means, and we'll get into those terms and definitions shortly. But the point I want to make first is that for each of these services, we look for national sources of data, and that might come from a health facility assessment or a routine data collection system like a health MIS. The JMP published a first baseline report on WASH in healthcare facilities in 2019, and at that time we had 260 national data sources in the database, representing assessments of just over 500,000 healthcare facilities from 125 countries. Now with this update, just 1 year on, we have 476 national data sources from 165 countries, drawing on data from nearly 800,000 healthcare facilities. And you can see that from 2019 to 2020, we increased the number of countries that have estimates for basic WASH services by about 50%, depending on the service area. Basic water and basic healthcare waste management have relatively good data coverage, with over 50 countries having estimates. For sanitation and hand hygiene, it's more in the range of 20 to 30 countries, and there are still only 12 countries with data on environmental cleaning. So let's look in more detail at the basic service levels and their definitions. For water, a basic service is defined as the healthcare facility having water that's available from an improved source on the premises. It's a pretty low bar. And here you can see that about 3/4 of healthcare facilities globally meet this service level. That's extrapolating from the 52 countries that did have estimates of basic services. We also define lower levels of service. The yellow bar indicates what we call limited services, healthcare facilities that meet some but not all of the requirements of the basic service. Maybe an improved water supply, but one that's located off premises, for example. And then in orange, you see the healthcare facilities with no services, which means that they used either water from an unimproved source or had no water source at all. And you can take either a glass 3/4 full or a glass 1/4 empty approach. This does mean that a quarter of the world's population, 1.8 billion people, lacked basic water services at their healthcare facilities. And that includes 1.1 billion people with limited services and 712 million who had no water service at all. Now, improved sources are fairly well monitored. This simply means water supplies that have some kind of sanitary protection that could include piped water supplies, but also boreholes and protected wells, springs, and rainwater harvesting systems. But these graphs show that a lot of improved water sources are not located on premises or do not have water that's actually available when needed. And it's also important to realize that a lot of the improved water sources that are located on premises are not piped water supplies. They might be boreholes, for example, or here on this graph, you see Papua New Guinea with very high coverage of improved facilities that aren't piped, mainly rainwater collection systems. The sanitation indicator is the most complicated one. A basic sanitation service is defined as the healthcare facility having improved sanitation facilities that are usable, but that also have toilets available for different types of users. There should be toilets dedicated for staff and also sex-separated toilets with menstrual hygiene facilities, and at least one toilet accessible for people with limited mobility. Globally, only 27 countries had enough data to make an estimate for basic sanitation services, and that's not enough to make a global estimate. More countries did have data to report on the no services level, which means that they used either unimproved sanitation facilities, like a pit latrine without a slab, or they had no sanitation facilities at all. So we can find globally in 2019, 1 in 10 healthcare facilities had no sanitation service. But there were enough data from 2 of the SDG regions, Latin America and the Caribbean, and Sub-Saharan Africa, to make estimates for basic sanitation services. And also, we could show that in the least developed countries, only 37% of healthcare facilities had a basic sanitation service in 2019. And here are those 27 countries, along with all of the elements of the basic sanitation indicator. And the gray cells show that some data were unavailable for some countries, and for now we can still make a basic service estimate if 1 or 2 of the elements are missing. But what this table shows is that in different countries, different factors are the limiting factors for the basic services indicator. In Azerbaijan, everything is near 100%, but less than half of healthcare facilities have toilets dedicated for staff. Frequently, data on menstrual hygiene management show lower coverage than for other elements. See, for example, Bhutan, with only 1 in 6 healthcare facilities having menstrual hygiene facilities in women's toilets. But even more frequently, healthcare facilities lack toilets that are accessible to people with limited mobility. Honduras is a good example of this. All of the other elements are 70, 80, 90%, but almost none of the toilets are accessible. And of all places, healthcare facilities are settings where people in wheelchairs or people with difficulty moving due to other health problems should be able to use the toilet. Speaking of toilets, the basic hand hygiene indicator is a composite indicator. It calls for healthcare facilities to have functional hand hygiene facility at points of care. That's where health workers are interacting with patients, but also at or near toilets. And there currently isn't a lot of data on water and soap in toilets. There were only 22 countries with national data on soap and water in toilets. So that means that we couldn't produce global estimates for the basic hand hygiene services indicator. But there is relatively high data coverage on the availability of hand hygiene facilities at points of care. There were 71 countries that had data on this in 2019, and we could make a global estimate that 68%, or just over 2/3 of healthcare facilities, had hand hygiene facilities at points of care. And this map shows the proportion of healthcare facilities that lack hand hygiene at points of care. The first thing to note is that most of the data we have is coming from low and middle income countries, especially from sub-Saharan Africa. That's where a lot of the global survey programs are focused. And I said that 2/3 globally of healthcare facilities had hand hygiene materials at points of care. Of course, that means that 1 in 3 did not have adequate facilities for cleaning hands where care is provided. And this map shows that there are even 12 countries in dark orange where less than half of healthcare facilities had hand hygiene facility at points of care. And this is a problem that doesn't necessarily need big investments in infrastructure. It's more about management and ensuring that hand hygiene and more broadly, infection prevention and control are adequately resourced. The basic waste management services indicator also comes in 2 parts. Waste should be safely segregated at the point of generation, and then wastes, including both sharp and infectious wastes, should be treated and disposed of safely. And globally, there were data from enough countries to say that 69% of healthcare facilities had some kind of waste segregation system, and just over 30% didn't. So nearly 1 in 3 healthcare facilities don't have systems for safe segregation of waste. And as you might expect, the situation is a little better in hospitals, where 80% of hospitals had systems for waste segregation. But there were fewer data available on treatment, and we couldn't make a global estimate of treatment of sharps or infectious materials, and so there's no global baseline yet for basic waste management services. But there were enough data from hospitals. Some data sources focus exclusively on hospitals, and there we could see very similar results. Around 80% of hospitals were treating sharps and infectious waste with some kind of basic treatment, and the other 20% were either not treating waste at all, or were using really primitive methods like open burning. Now, in some cases, that might be the best available solution, at least in the short term, but it is far from a normative practice, and it doesn't count towards the basic service level. So when you combine the data on segregation and treatment, you find that 71% of hospitals globally had basic waste management services in 2019. Lastly, environmental cleaning. This indicator is a bit different. The other services are based on physical things you can check and confirm objectively. Are water or toilets or segregation and treatment facilities available? But it's much harder to check and observe environmental cleaning consistently and objectively. So instead, this indicator focuses on processes. Are there basic protocols for cleaning available, like standard operating procedures? And have all the staff who have cleaning responsibilities received training on cleaning? This is still a new indicator and hasn't traditionally been in the facility assessments and other data sources that we draw on. So currently we have only 12 countries with national estimates. But that is growing quickly. There were only 4 in the first report just last year in 2019. And you can see a real range of coverage. Some of the high-income countries already have universal coverage, but there's a range, for example, from almost very high coverage in Thailand to very low coverage in places like Bhutan or Niger. Like hand hygiene, this is an indicator that in principle could be improved rapidly with relatively small financial requirements. It's more about strengthening the approach to cleanliness and the focus on infection prevention and control. And these are things that a committed administration can change relatively quickly if they put their minds to it. And we certainly do see examples of countries focusing on improving cleanliness and IPC and overall the quality of care. We're going to hear some examples of that in the next part of this presentation. So that was a quick tour of the data highlights. Please do look at the report in more detail, and all of the data can already be explored online at washdata.org. Now, let me pass over to my colleague, Maggie Montgomery, who will talk about the broader work on WASH in healthcare facilities.
Thank you very much, Rick. If you could advance to the next slide, please. So we all know that lack of WASH has a big impact on quality of care. I just wanted to highlight one specific number from this slide, and that's 5 million deaths. And these are the number of deaths that happen every year in low and middle income countries because of poor quality care. And this is actually a bigger number than those dying from lack of care. And obviously, there's more to quality than just WASH, but WASH is a fundamental aspect. And it's not just about infections, it's about care seeking, it's about health worker satisfaction and motivation, it's about human rights. Next slide. So on the next slide, we also know that WASH in healthcare facilities is something that women want and that women are demanding. These are the results from a survey that was done by the White Ribbon Alliance, and we're very fortunate to have someone from the Alliance speaking during the Q&A, so please stick around. Of over 1 million women, and water, sanitation, hygiene was the #2 demand for maternal and reproductive health services. And this is really important because we find that often the maternity ward is the ward that has the least amount of WASH services, even though other parts of the facility may have better services. So fundamentally, this is also an equity issue and something that needs to be addressed. Next slide. So the resolution, if you haven't heard about the revolution, you're going to hear about it right now. In 2019, all 194 member states of the World Health Organization passed a resolution specifically calling for better WASH in healthcare facilities. And what's really unique about this resolution is it references the 8 practical steps. So the 8 practical steps are a distillation of what we know works in countries. It was produced last year by WHO and UNICEF alongside the baseline data. And the steps are outlined here, starting with conducting situational analysis and assessments all the way through conducting operational research and learning. So these steps give a very strong foundation for not only what member states agreed to, but also for tracking progress and implementing these commitments that were made last year. Next slide. So just to give a quick snapshot, we have data in the report from 47 early adopter countries. We see that nearly all countries are in the process of either updating their standards or implementing their standards. And updates are often linked to climate, to be looking at no burn technologies for healthcare waste or recycling, but also looking at aspects of antimicrobial resistance and other emerging threats. We also see that nearly 75%, or 3 in 4 countries, are in the process of completing or have already completed a situational analysis that involves not only the understanding the service aspect of WASH, but also looking at policies and standards and linkages with all the many health programs through which WASH in healthcare facilities becomes quite important. However, if we look at indicators around dedicated budgets and look at integration with health, and specifically we're looking at whether or not WASH indicators are within the regular health systems monitoring, we see that there's many fewer countries. Only 1 in 3 have plans with dedicated budgets, and less than 1 in 10 have integrated WASH indicators into their health systems monitoring and are regularly looking at WASH access as part of their overall health sector review. Next slide, please. So this is a little bit hard to read, but this hopefully will give you a teaser to download the report and take a closer look, especially for those of you who are working in country and want to know specifically, for example, what's happening in Indonesia or in India. This is the progress of 5 of the practical steps. And again, these are all committed to in the resolution. Green means that the activity has been done, it's been completed, it's been disseminated. And we see there's definitely more greens if you look at some of those earlier steps around situational analysis, around setting up a national committee and having a national roadmap. And as you go farther to the right on this plot, there's a lot more orange and reds. And reds means it hasn't even been started. Orange means there's been some preliminary effort, but there's still a lot more work that needs to be done. And this is around the budgeting, around the sustainable infrastructure improvements, and around the truly operationalizing this work and integrating this work with health. Just to comment that we do hope to increase the number of countries that are in this tracker before the World Health Assembly in May 2021, which is when the official reporting back will be on the progress of implementing the resolution. Next slide. As Rick mentioned, there's a number of case studies in the report. There's 30 altogether, and these case studies were selected because The efforts are national and at scale. There's a strong coordination and strong government leadership, but also there's multiple partners who have come together around one plan and one initiative. And I'm just going to highlight a few of them here. You can read about them in more detail in the report. So Ghana has done a number of things. And one of the interesting things is that they've engaged the communities in community scorecards, which are semi-qualitative, and they look at a number of quality aspects, including WASH. And these scorecards are actually integrated with their health systems monitoring. So alongside the concrete indicators within the healthcare facility, they also have the community indicators, which really allows the coming together of both aspects of this work. We also have an example from Bhutan, where they've been able to innovate very quickly a new hand hygiene facility, which also serves the purpose of treating water. It was developed locally. It's now been scaled up to a number of hospitals in Bhutan. Philippines and a number of other countries have done some amazing work on climate. And we hear a lot about COVID, but we also know the climate crisis continues to become more and more important, and making sure that WASH services, along with energy service, are resilient in healthcare facilities is fundamental to improving the way in which we can handle climate change. Cambodia has really been a trailblazer in looking at institutionalizing WASH within their quality work, within their quality monitoring, but also within their payment system for quality. And lastly, from the first ladies in the Americas, we have a number of them, including from Colombia, who have taken on this cause as a social cause and have been able to rally a lot of support and interest and leadership from their seat of influence. Next slide. But we also found through writing this report and working with many of our health colleagues that integration is incomplete, especially at the country level. So at the global level, we're very pleased to see that WASH is in many global health standards and strategies and policies. But if you go down to the national level and the subnational and the district level, it's often lacking. And here on the left, you can see that care is really looked at through 7 lenses of quality. And I just want to highlight that WHO just published 2 weeks ago a new guide on quality planning, which very specifically gives recommendations for how WASH can be embedded in quality processes at the national, the district, and the facility level. There's a number of programs that we go into a bit more depth in the document, for example, on infection prevention control. Obviously, it's really fundamental to the work on hand hygiene, which is hopefully you've all heard more about it with COVID, and linked as well to the Hand Hygiene for All initiative, which UNICEF and WHO launched earlier this year to make sure that not only was access to hand hygiene available everywhere to everyone, but that the behaviors are supported in practice. Also maternal and newborn health, it's obviously quite critical. There's the Quality of Care Network for Child and Maternal Health, which is focusing on 11 countries to cut in half maternal and newborn deaths. WASH is one of the key standards in that. And within this report, I'm proud to say that 8 of those Quality of Care Network countries are featured, but there's still more that can be done in terms of monitoring, in terms of co-programming the WASH work next to the quality of care work, and also around the training and the capacity support. Next slide. So the price tag, Kelly mentioned earlier on that we've done some preliminary analysis to look at what would it cost for all 47 least developed countries to supply and sustain universal basic WASH in healthcare facilities. And the number is actually quite moderate in terms of if you look at the cost of other items for health and you look at overall budget. So we found that it would cost $3.6 billion. This is from 2021 until 2030. The majority of the cost is for the operation and maintenance. So this comes to 2.4 billion. 1.2 billion is for the capital. And if you look at it a per capita per year, you have 10 cents plus 20 cents. So it's 30 cents per capita per year to get those facilities up to at least the basic standards. Next slide. And as I mentioned, these costs are quite modest. And this plot here shows some of the other funding and spending that is going into WASH and to health. And I just wanted to highlight a few of the numbers here. So if you look at the big red dot kind of halfway down, that's $10. That's what governments are spending every year on health. If you go to the next big dot, we're looking at the annual investment needed per capita for universal basic WASH. So this is in all households in least developed countries up into 2030. So the annual cost for healthcare facilities are just about 3% of the annual recurrent government spending on health, and similarly about 3% of the annual universal basic WASH price tag. Next slide. There's a number of other issues that are discussed around costs and investments, and we're really grateful that we had the World Bank leading the drafting of that chapter in the report. Some things I just wanted to quickly highlight is that the lack of financing obviously undermines sustainable services. And we know that from the WHO GLASS report that came out last year that only about 11% of countries have stated that they have sufficient resources to meet their WASH and healthcare facility targets. Now, we also know that there's a number of things that need to happen to make sure that we have sufficient budgets and financing. First is simply disaggregating the budget lines. Right now, it's very hard to even know what is being spent and what it actually costs for WASH and healthcare facilities. So this is really important to make it more visible. There obviously needs to be a rigorous process to gather the costs and be really clear about what are the WASH and IPC packages. Investments in operation and maintenance, we tend to see there's a big focus on putting in the capital and much less so on all the costs. And as I mentioned, those O&M costs are actually greater over time than the capital costs to make sure those services can be maintained. And then lastly, just to highlight that there needs to be intersectoral dialogue and planning between the ministries of finance, between ministries of health, ministries of water and infrastructure. The last point just to highlight is that the use of not only whole systems planning, especially at the district level, can be quite important, but also the flexible use of funds at the facility level to make sure they have discretionary funding, whether it is to change a light bulb or to fix a broken toilet. Next slide. Commitments, we have a number of commitments. We have over 130 partners that have committed resources. 34 of these have made financial commitments. We'll hear from several of our key partners in today's webinar. You can go to the washinhcf.org site, the commitments page, to see all the commitments that have been made, but also to make your own commitment as well. And we'll continue to look at these commitments and track these over time. Next slide. So I just want to quickly run through the 4 recommendations. Next slide. So the first one is that we know countries need to have costed national roadmaps with appropriate financing. And we have a few examples of countries like Ghana who have these roadmaps and have put the costing in place, but there's many more that need to develop these roadmaps. And I just want to emphasize that these roadmaps potentially could be standalone, but regardless, they need to be well integrated and well discussed with health colleagues, because again, we can't be implementing this work in a silo. Next slide. The second recommendation is around monitoring, around regular monitoring and review of progress on improving WASH services. And this monitoring needs to particularly be strengthened, for example, on the data service side around environmental cleaning and sanitation. As you heard from my colleague Rick, data on this is especially lacking, but we also have gaps around higher levels of service. And you'll hear later from Serbia what they're doing to try to define what those higher levels may be. Indicators need to be incorporated not only into facility assessments and health systems monitoring, but also around quality of care improvement cycles. And this data regularly reviewed and assessed to understand how to allocate resources and also how to reprogram certain activities. And then lastly, we call for efforts to continue to track implementation of the practical steps and the resolution and to strengthen these as well. Next slide. The third recommendation is around the health workforce and developing their capacities. So we know that sustaining WASH services requires dedicated and trained and compensated health workforce, and especially around cleaning and healthcare waste, which has a particular skill set. We also are quite clear that all staff should obviously be supported to practice and serve as good models for hand hygiene, and this can't be more important than ever because of the current epidemic that we're facing. And lastly, that the tool WASH Fit, which is a mechanism to empower staff to incrementally improve and sustain WASH services, needs to be further adopted, further developed and used alongside broader initiatives to improve quality of care. Next slide. So the last recommendation is really the fundamental recommendation that underpins everything, and it's about integration with WASH into regular health sector planning, budgeting, programming, including within COVID-19 response and recovery efforts. WASH and waste services are common goods for health, and there's an increasing push within the health financing to look at these common goods and to make sure they are appropriately financed in order to achieve our health aims. Obviously, all COVID-19 response, and we're coming up to a major vaccine effort, and more broadly, the economic recovery plan should monitor and budget for WASH and healthcare facilities, and this is particularly important around hand hygiene and around waste, if we're looking specifically at the vaccine. And lastly, around the Build Back Better, that these improvements for WASH should also at the same time address climate resilience. And this is actually a key prescription in WHO's manifesto for a healthy recovery. Next slide. So I'll end here and make a call to all of you who are on this webinar today. You are obviously very interested and committed to this issue. So it's time to step up our efforts, not only our individual efforts, but our efforts as members of organizations, but also collectively to make sure that the vision, which has been set and agreed upon by all countries, can actually be achieved. Next slide. So please, if you haven't been engaged, I ask you to get engaged and ask for your committed efforts and action moving forward. You can learn more on the WashingHCF.org knowledge portal. So with that, I'll hand it over to Everest Kusakuman, who is the Regional WASH Advisor for East Asia and the Pacific from UNICEF, who will be moderating the next section. Thank you.
Thank you very much, Maggie. Fantastic to hear from you and also to see there's a lot of case study, a lot of recommendation and new thinking going on. This section is more about the country and partners' reflections on the report and what Maggie has shared also now. So we have listened to them, and then on the report, the case study that shows some good experiences and also the way forward. So we have 4 countries that contribute to those reports, those studies with us today on this panel. And from Philippines, we'll be having Dr. Rosaline Dianzong. From Mali, we have Dr. Musa Aghama, and then from Serbia, Dr. Dragna Jovanovic. And then and then you have one key partner also contribute with to this from WaterAid, Shiluva Siloshe. So for the first presentation or for the first reaction, we are going to hear from Philippines how basically they are making progress in WASH and healthcare facility while at the same time incorporating climate resilience like Maggie talked about and also mainstreaming that into primary healthcare. So unfortunately, we are going to have a very quick video for that, and over to you. If you can put the video online, it might be very good.
Intervention from the Philippines by yours truly, Dr. Rosaline G. Bianson from the Disease Prevention and Control Bureau, Department of Health, Philippines. Good morning, everyone. It is already evening here in Manila, but our technology was able to make it happen despite the differences in time zones. First of all, I'd like to thank the World Health Organization for giving the Philippine Department of Health a chance or an opportunity to share what we are doing right now in the Philippines with regards to WASH in healthcare facilities. We are glad that for the last 2 years, this somewhat long-time neglect of giving attention to water, sanitation, and hygiene has become a priority. How much more in these pandemic times where additional resources are being mobilized for healthcare facilities to address COVID-19. We believe that by licensing a healthcare facility, the health services, including WASH, will be improved as part of the requirements of the Universal Healthcare Act. Integrating all efforts is really very challenging as this requires funding to realize the goals envisioned in the Sustainable Development Goals and in our own national objectives for health for improving the current situation. COVID-19 has been a game changer on how we prioritize things for almost 9 months now. The funding of our regular programs for this year were refocused and repurposed to COVID-19 response. Our budget next year will somehow increase to support healthcare waste management. The Department of Health's Health Facility Enhancement Program continues allocating funds for infrastructure component of government healthcare facilities that include WASH facilities as part of the basic yet current standards. In addition, key donors and developmental partners shift their support to COVID-19. As of November 30 this year, the WHO Philippines reported that about $230 million were already mobilized for COVID. Although WASH is very minimal from this basket of funds, the Philippines has developed its own master plan for water and sanitation that outlined the resources and has developed financial mechanisms needed in reaching universal coverage of WASH by 2030. I wish also to acknowledge key support on WASH and climate change from our development partners, in addition to WHO and UNICEF, such as USAID, World Bank, Asia Development Bank, and the UNDP or United Nations Development Program. Currently, we are finalizing a project proposal to Green Climate Fund to support our needs on strengthening the resilience of our healthcare facilities against the impact of climate change. Let me end by saying that there is light at the end of every tunnel. While we have been in this midst of pandemic, the Philippines has been in all these typhoons. We hope and we believe that with efforts we are doing right now and the lessons that we are getting from the pandemic experience, the game changer has done its part of shaking the system so that there will be cooperation and integration to recover from these challenges. And as such, we continue to move forward for better environmental and health services, not only in the country, but in the whole wide world as well. Once again, thank you for the opportunity and good morning to all.
Thank you very much. Thank you very much. A very nice point, Dr. Rosaline, very nice, and I'll point out the fact that we basically, Philippines will increase the budget and also make sure there's a green associated to washing healthcare facility. Next, we will hear from Engineer Moussa Aghama, Direction Nationale de la Santé du Mali, la Direction Nationale de la Santé du Mali. Also, they have a very small prerogative video for us. Mali is a country that has made a gain from a small incremental improvement, and how we have engaged also in many, Mali has engaged in many organizations in planning, implementation, monitoring, incremental improvement. This is what we are going to see from Mali as well. Over to you for the video from Mali.
Mesdames et messieurs, bonjour. Merci d'avoir invité le Mali.
Ladies and gentlemen, good afternoon. Thank you for giving us the opportunity. I'd like to remind you of the fact that since 2012, we've had a serious economic and political crisis that has hampered a number of our activities, notably WASH. Until 2015, since 2015, we now have a new form of resilience. First, we have developed a number of tools, a number of a WASH training tool that was followed by the development of what we call the basic package for access to health. This is our reference document regarding the WASH. There's also been the arrival of WashFit in Mali, which we've implemented in a number of districts. First, we had training of actors at the central and regional levels to have a number of WashFit trainers. The WashFit was implemented in 6 sanitary districts. In parallel with that, we've also worked with other actors. We've used other tools to improve WASH services, which are not the WashFit. The WashFit has complemented the work that was done by several actors, and this is something we could implement in 15 other sanitary districts in Mali. Then we were also able to organize with our WHO partners a roundtable on WASH in Mali. This initiative derives from the WHO resolution of 2019. After that roundtable, we've organized another meeting to draft a plan to implement that resolution in Mali. The first activity was the integration of WASH indicators in the national database. We were able to do that by adapting those indicators to those given by the national GIMP body. With the COVID-19, though, we had to organize a series of training modules, notably the national trainer training to infection control and prevention. We've also trained 300 agents in Bamako, but also in a number of distant regions. We were able to organize a number of other trainings, and we were able to train 170 ambulance drivers and cleaning personnel. In terms of the training challenges, the first one is the issue of security, the access problem, because there are many reasons we cannot access for security reasons. There's also another challenge related to personnel mobility. There's also the fact that the first WashFit training was carried out 4 years ago already, and we need to the WashFit tool. The last challenge I wanted to underline is related to WashFit itself, the need to adapt the tool to the national context, especially given the age pyramid, the sanitary pyramid. You have a number of different levels of hospitals, so we're going to be able to adapt this tool based on the need and the needs and the level of sanitary provision.
Okay, thank you. Thank you very much. We cannot hear the last, but it's fine. So thank you very much, Dr. Ingénieur Moussa Ahmad, Direction nationale de la santé Mali. very clear, une bonne présentation sur le Wash Fit. Et puis la table
That was
ronde
an
avec
excellent
l'OMS
presentation on
qui a
Wash
été
Fit and
organisée au
the
niveau du
roundtable
pays.
with
Et le
the
plan
World
de
Health
mise en œuvre qui
Organization.
est découlé de ça, quelques défis ont été soulevés. C'est le défi d'abord lié à l'adaptation de Wash Fit au contexte local et aussi à l'accès dans les zones vraiment difficiles. Donc, thank you very much for all those, the capacity building effort that you have basically put in place and also the planning related to that. Thank you. Next, I would like to introduce you to Dr. Dragna Jovanovic, Director, Institute of Public Health, Serbia. Hi, Doctor. Can you put your video on if you are there?
Yes. Hi.
Yeah.
Yes.
Happy to see you. You have seen all those presentations, the progress, the case study in the Philippines, Mali. How have you been able to use data in Serbia to improve monitoring of WASH in healthcare facility and set up a high standard in Serbia?
Yes, thank you very much. I would like to send greetings from Belgrade, capital of Serbia, and to wish good afternoon to everybody. Actually, thank you for this opportunity to share Serbian viewpoint on monitoring and review of progress and how we see that we can put the recommendation into action. Please, next slide. Actually, in 2019, the Republic of Serbia conducted a comprehensive analysis and assessment of WASH situation in healthcare facilities, being among the first countries responded to the World Health Assembly resolution on WASH in healthcare facilities. As you can see, these assessments revealed a very low coverage of basic sanitation, only 6%, as the most challenging outcome of this survey. When it was broken down into individual estimates of the criteria for the basic sanitation services, it showed that investigated healthcare facilities had usable sanitation services in place, but not meeting the needs of women and girls and of patients with impaired mobility. In 2016, please, next slide. In 2016, Serbia integrated GMP WASH in healthcare facilities core indicators into a national monitoring system, and based on the survey findings, defined the indicators for advanced level of WASH services, and currently we are working on their integration. I can give you an example of advanced indicators. We defined them for water, cleaning, waste, medical waste management, and hygiene. But as you could see our results for sanitation, we think that we need still to meet the basic sanitation criteria. And for example, as an advanced level indicator, I can mention here that for water, drinking water, we defined that each healthcare facility should meet drinking water quality standards as per national guidance and definitions, and also to have a hygiene plan in place, and also trained personnel and the dedicated WASH team or IPC team that will operate and maintain adequate WASH within facility. This was only for illustration, and you can find more detailed information in our published report on the survey results. In addition to this, based on the survey results, we also integrated WASH and IPC in a new regulation addressing drinking water quality and training on healthcare workers workers and staff on WASH aspects in healthcare facilities. When it comes to concrete improvements of WASH infrastructure in healthcare facilities, either renovation or construction of a new facility, we learned that we need to establish a good and regular connection with architects, designers, infrastructure entities to ensure all standards of safe and dignified WASH are met in construction and renovation. Actually, we found out that that is a really huge challenge when it comes to concrete infrastructure improvements of WASH in healthcare facilities. With that, I would finish my intervention, and thank you for this opportunity.
Thank you. Wonderful, Dr. Dragana. I think it's very clear that based on the assessment, you have developed a high standard, national standard, basically, and then the plan is to engage the architect, the designer, basically to support the infrastructure design as well. Thank you very much. Very nice contribution from your side. Next, I will look at you. I would like to introduce Chilufa Chileshi. She's interim global policy director, WaterAid. Can you put your video on, please?
Yes, thank you.
Thank you. I'm very happy to see you again. I have a very quick question for you. So we would like to hear from your perspective on the importance of connecting the national policy and technical dialogue. We will also be interested in knowing more about your experience in empowering the health workforce and what will be the impact if you have, you have done that or you have seen that.
Sure, thank you very much. So, so WaterAid has quite a lot of experience working in several country programs in Africa and in Asia, focused on WASH in healthcare facilities. And in January this year, when Dr. Tedros highlighted that keeping healthcare clean is one of the most urgent challenges for the coming decade, we were very excited by that call for action, but also it's one that we took very seriously as a validation for the importance of the work that we're doing in healthcare facilities, supporting not only the national level response, but also at the points of delivery. But of course, at the time in January, when Dr. Tedros made that call, none of us could have imagined how soon or how far that commitment or call to action would be tested. So in the context of COVID, I think we have all seen that the effects on healthcare workers have been a lot greater than on the general population. We have also seen that, where conditions are unhygienic in healthcare facilities, it affects retention, motivation, and safety. And generally, from our experience working in healthcare facilities, it's quite clear that it's impractical for healthcare workers to feel empowered and to work in those settings if conditions are unhygienic, if they lack a decent toilet. We have testimony or statements from many healthcare workers on the front lines during this time of COVID, wearing PPE, struggling with menstruation because they couldn't access a toilet easily, or unable to drink too much water and therefore being dehydrated because they were not sure that they could find a toilet. So those are some of the challenges that we find that require national level understanding of the extent of the problem, but also action at the points of delivery where these healthcare workers are. But empowering healthcare workers depends on a lot more than just healthcare workers. So I want to suggest that three things from our experience at WaterAid, or rather three actors that we think need to be focused on and invested in. So the first, of course, is the healthcare workers themselves. So how do we make sure that there's accountability and action and investment in their work environments, ensuring that the conditions are hygienic and safe and that they motivate them? How do we make sure that there's training and retraining so that healthcare workers, including cleaners, auxiliary workers, everybody that's handling medical waste and so on, is adequately supported? That empowers them to do their job properly. It keeps them motivated and allows that the services be of quality I think it's alarming when we see from the report that 5 million deaths result from poor quality healthcare, and we know that healthcare workers are at the heart of this, so empowering them is key. The third actor is communities around these healthcare workers. How do we empower communities and ensure that all processes around ensuring that we have WASH in healthcare facilities or that we can achieve UHC includes communities, that communities are able to participate, that there's mutual accountability between them when they access the services or in their various leadership roles are able to support healthcare facilities towards ensuring universal health coverage. The third is governments, and I think that we want to see national governments at all levels, whether they are working, whether we are looking at district level governors or the national level policy dialogue that's happening, that they're championing mechanisms that enhance accountability at all levels in this case. And I think we have seen some really good examples in countries where we work, where we know that this is possible. So I think it was Maggie speaking earlier, gave the example of Ghana. And we know that our WaterAid team there has played a very active role supporting the rollout of community scorecards and engagements, using that and the findings of those community scorecards, using that information to ensure that we uphold health users' rights, respect and improve IPC, but also ensuring that we can input into health MIS. Two last examples, very quick one, Chair. In Myanmar, our WaterAid teams working on the Teach Clean approach to improving environmental cleaning practices for frontline cleaners. And in Malawi, we have worked directly with communities that are supporting WASH in healthcare facilities, and at the same time improving citizen capacity to mobilize and organize. So I think the point I really want to leave here is that empowerment is beyond healthcare workers alone, that there are various actors that need to support that, and organizations like WaterAid also really keen to play a part in making sure we can drive this. Thank you.
Thank you, wonderful. I think those 3 points are well captured, and thank you very much for that. The health worker, how we empower them, as well as the accountability, the government, leadership, and also the community around the healthcare, facility are very important. Thank you. I would like again thank very much Dr. Rosaline, for the presentation. Dr. Musa, Engineer Musa Aghamed, Dr. Dragana, and also Chirufa for their nice, contribution and to the discussion. So you can see for each of those countries, they address a different thing. I will quick point a few for us. One is a green and safe concept that is developed by the Philippines, which is very important as an adaptation to respond to the climate change, which is coming very strongly. And then you can see also from Serbia how, based on the assessment that they have developed a high-level indicator at national level, basically to support the whole process and align with GMP. In Mali, you see the whole capacity building using WASH Fit who come in, and also, although they are having some difficulty due to the insecurity, they are trying basically to do their best, training more people, and then, WaterAid, your contribution, very, very, very nice. The 3 key points, the health workers, employment, the community around, and also the government, to support the whole process, very important. So thank you very much for that. And I would like, I'm finishing this session, I would like to introduce you to Dr. Sham Said, who is the lead quality of care WHO, to talk about WASH and quality. Over to you, Dr. Said, if you are there.
Thank you so much. That's great. Thank you, Everest. And just, I know time is short, so I'll keep very brief in my remarks. It's been great to hear so many different perspectives and so many different dimensions of this conversation coming through today. very powerful, starting from Kelly to emphasize the senior leadership commitment to this issue, and of course, a member state commitment to this issue, and going right back to Mary and reminding us that our health workers are depending on us for action. The data that Rick presented was very clearly data that calls for action. And of course, we're making very clear linkages with the quality of care agenda. Maggie really outlined this very beautifully, particularly through the use of some country experience and case studies, really emphasizing all of the different interconnections and the recommendations, the 4 crystal clear recommendations that emerge from this report is something now that can guide us. And Everest has done a wonderful job at moderating this last session, which heard so many nice pieces from the 4 colleagues. 3 quick points from my side. It's been said, but just to reiterate, we need to make the links between WASH as a fundamental and foundational aspect of quality of care at all levels, predominantly the facility level, but importantly, the district level and the national level. We should remember the contextual realities, and let's also remember that 2 billion people on this planet live in fragile, conflict-affected and vulnerable settings that needs adaptation and context-specific action. At all levels, of course, when we talk about quality of care, we always emphasize the critical importance of patient safety, and needless to say, but important to reiterate, is the linkage between WASH and infection prevention and control. Today, my second point, we see the launch of the PHC, the Primary Health Care Operational Framework. We do need to ensure that WASH is embedded within the efforts when it comes information that exists within this report tells us.
Hello, Dr. Shams, Syed. I think you're having connection issues. Maybe you can, we'll let you wrap it up and pass it over to Tom.
Great. Okay, thanks, Maggie. I was just handing over to Tom. Were you able to hear my 3 points? Perfect. Over to you, Tom. Thank you so much.
Okay, thank you, Shams, for a nice summary. My name is Tom Slowmaker. I co-lead the Joint Monitoring Programme. I work on the UNICEF side at UNICEF headquarters, and together with WHO, we're responsible for global monitoring of WASH in healthcare facilities. You've seen the data. You've heard from a number of different people about ongoing efforts to address this problem, and we have just 4 more speakers lined up for you. So I know we're running a little over time, but I'd like to go for another 15, 20 minutes, if that's okay. The first of our speakers will be Dr. Engineer Diallo, who is the National Health Accounts Coordinator at the Ministry of Health in Guinea-Bissau. We also have Dr. Norahasina Rakatarisson, who is the Head of Health and Environment at the Ministry of Health in Madagascar. And we're going to hear from Christiana Asala, who is the National Coordinator of the White Ribbon Alliance in Nigeria. And last but not least, from Greg Allgood, who is Vice President of Water for World Vision. Just building on what we have heard already, I'm going to go to Dr. Diallo first. And I'd like to hear about the work that's been going on in Guinea-Bissau. Many countries have very significant data gaps, as we saw from Rick's presentation and also from the report. So Dr. Diallo, could you tell us what are the innovations that you've been working on in terms of data collection for monitoring WASH in healthcare facilities? And what are the main challenges that you found when it comes to collecting data on WASH in healthcare facilities in Guinea-Bissau? let me try and bring you in.
Ok, merci Tom. Moi je suis Boubacar Diallo, je travaille au ministère de la Santé. Je suis au niveau de l'administration du système de la santé et aussi coordonnateur des comptes de la santé. Je parle aujourd'hui au nom du ministère de la Santé pour répondre à la question qui a été posée par M. Tom, ce qui concerne le programme WASH au niveau de la Guinée-Bissau. Je vais commencer par le remerciement du service de WASH au niveau de l'UNICEF Guinée-Bissau, qui a eu l'initiative de... Nous avons beaucoup de choses ici, mais on n'avait pas l'initiative de penser ce qu'ils ont pensé pour nous. Malgré qu'il y a la qualité du soleil et aussi l'environnement, tout est là, mais on l'utilisait très mal. Mais avec l'initiative de l'UNICEF, ça nous a permis de comprendre beaucoup de choses et nous les remercions beaucoup. En ce qui concerne le programme, nous avons suivi avec intérêt toutes les activités qui ont été produites par l'UNICEF au niveau de la Guinée-Bissau sur la réhabilitation, la reconstruction des centres de santé avec de l'électricité et de l'eau qui est abondante dans le pays, mais on ne savait pas l'utiliser.
Were in the country, but we didn't know how to use them, and thank you very much for having shown us how to use them. And now UNICEF has created a joint program with the World Health Organization, which is also working on the monitoring of the data. And what we have, the progress that we've made with UNICEF is the use of data. Because using the data, we were able to have data, for example, at the time of COVID, we in fact worked with the WaterAid application to try to gather together all the data together, but just by using the phone. So for example, we're in our offices, we can make a call, we don't have to move, we call a health center, we ask them for all the information that we need at our disposal. And we have somebody who's responsible for data management who records all the data that we've received, and so we in fact put that data on a platform which is called MWater, and it was in fact established by the managers of UNICEF data, and that meant that we could have all that information without moving, and that was a terrific opportunity that we received using MWater and WASH. And another thing that well, this isn't part of the actual question, but our project, our initiative now is to create a committee to have a maintenance committee, because we have 78 health centers that were set up in order, that exist there, that have got electricity and they've got water, but at the same time we want to be able to have a maintenance committee to be able to carry out the activities, and also to train people responsible for introducing the data into the health center or to community level, without again having to go there. And at the time of COVID, of course, that's something that's essential. So that's what I wanted to say, and we also want to be able to pursue the coordination of this project. It must continue, because 78 centers, we have 142 health centers altogether, but 78 are different to all the others, and we would like for the project to continue so that we can actually also apply it to the other centers. Thank you very much.
Thank you very much, Dr. Diallo, and a very interesting example of an online monitoring system and how that has been used to inform the COVID response in Guinea-Bissau. Now, our second speaker is Dr. Norahasina Rokitara-san from Madagascar, but I can't see her online, and I have a message to say that she's having trouble connecting. she has just sent me a message about the things she wanted to say. So I'm just going to briefly read those out and then we'll move on to our next speaker. In Madagascar, they've been doing some very interesting work to develop new standards and also to upgrade the infrastructure for WASH in healthcare facilities, with a particular focus on healthcare waste management. So they did a big study in 2015 to look at the vulnerability and adaptation to climate change. And they have developed a decree which is now being implemented across the different ministries to make sure that all new facilities are adapted and resilient to climate change. And the second thing that they've been working on is management of waste and trying to reduce pollution from healthcare facilities through the development of autoclaving systems in the major hospitals. And they've been successful in reducing the amount of mercury that is being released into the environment. But there are some real challenges still with healthcare waste management. And this has been highlighted again during the response to COVID. And at the moment, they're particularly concerned about healthcare waste management outside of the major hospitals. So looking at the smaller healthcare facilities, which are mainly relying on municipal waste systems, which are not really well equipped to sort and safely manage and dispose of wastes. So that is going to be a big focus going forward. But some very interesting work going on there in Madagascar, and thank you very much to the Ministry of Health for sending that case study through. I would like to move now to our third speaker, and that's Christiana Asala. Christy is the National Coordinator of the White Ribbon Alliance in Nigeria and is an advocacy and communications professional, has been working across sexual, reproductive, maternal and newborn and adolescent health, with a particular focus on behavior change, and is working in around 16 states across Nigeria. We heard in the initial presentation about women and girls identifying WASH in healthcare facilities as a top priority for quality reproductive and maternal health care. Christy, can you tell us a little bit about how you will be moving forward with the White Ribbon Alliance in terms of trying to embed WASH into health programs? And what recommendations would you make in terms of advocacy and communication strategies?
All right, thank you so much, Tom, for those questions. Since our earliest days, White Ribbon Alliance has worked to ensure that women's voices and demand are the center of health policies, programs, and practices that impact their lives. Now, when we launched the What Women Want campaign that heard from 1.2 million women about what they needed for quality reproductive and maternal health care, we had no idea that women would overwhelmingly demand for WASH. And within that request, that the biggest demand would be for simple cleanliness. Women ask for clean facilities in the labor rooms, maternity wards. Now, these are not unreasonable requests. In fact, they should be a given in the health facility. But for time and time again, nobody has paid attention, and women have been asking for these same things. Now, so the White Ribbon Alliance will continue to elevate demands of women in their own words. Now, to everyone who is able to change the status quo, we will share experiences like that of Abigail, a 33-year-old mother of 4 in Niger State, Nigeria, whose priority wants in quality maternal health care is access to clean water and toilets in health facility. Unfortunately, she didn't have that when she gave birth to her 4th child, and has discouraged her to further access healthcare facility. Now, that is not any experience anyone wants for themselves, or a bad experience we would want for our loved ones. Now, advocacy strategy we are looking at is a bottom roots top approach. because we know real change happens when people demand it from those in power. This has been true with every social movement. It is the same with WASH. As more women refuse to give birth in untidy health facilities, as more midwives demand to practice their profession of caring for women and newborns with basic decency, now the more it will become apparent that water, sanitation, and hygiene is not a given within health care settings. As that's reality set in, those concerned, we hope, will, with health, gender equity, nutrition, economic development, and most importantly, human rights, will unite to elevate WASH as a priority across sectors. It will not be until a grassroots movement takes hold that those with most power to change the status quo will respond action. Now, what does this mean? Women must be part of the decision-making process. That is the only way we will see sustainable change that is responsive to actual needs. We have seen this work in Nigeria, for example, in response to the women's demand from What Women Want campaign and to WRE Nigeria's advocacy on behalf of what women told us. The Niger State Primary Healthcare Development Agency committed to installing at least 6 toilet facilities within each of the state's 274 focal primary healthcare centers. That is double the original number per health center. Now imagine what it will look like if women are listened to everywhere. Thank you, Tom.
Thank you very much, Christy. Really nice to hear the emphasis on the demand side and listening to women demanding change from decision makers from the bottom up. And also some nice examples of that really working and starting to see improvements on the ground as a result of communication and behavior change campaigns, and putting women at the center of decision making. All really strong recommendations. I'm now going to turn to our next speaker, who is Greg Allgood, Vice President of Water for World Vision. And Greg leads the establishment of alliances with corporations, with foundations, with individuals in World Vision's efforts to improve water services for millions of people around the world. Greg, I am going to try and unmute you. Okay, you're unmuted. I know that World Vision has made a commitment to provide WASH services in 800 healthcare facilities between 2019 and 2021. You're partway through, and this would potentially reach an estimated 7.2 million people and cost about $100 million US. So this is a huge commitment. How's it going? And how are you going about trying to integrate the work that you do on WASH and on health?
Thank you, Tom. It's going very well, actually. I'm pleased to say that we're on track with the commitment. In fact, we're ahead of schedule, so we should reach the 800 rural healthcare facilities prior to the end of next year. And when we do, we plan to make another and even bigger commitment because this work is so critical to health. And we're grateful to our partners that have made this happen, including governments, corporations, and foundation partners, private investors, and academic groups that we work with, like the UNC Water Institute. Of course, 2020 has been a year unlike any other. Prior to the pandemic, we galvanized support for this commitment by focusing on the benefit of ensuring a safe birth experience for mothers and their newborns. Frankly, it was about ensuring that the miracle of birth does not become a death sentence for mother or child. We did not use any language about protecting frontline healthcare workers or preventing the spread of deadly infectious disease. But as the pandemic began, we made a huge pivot in our communications. We literally rewrote the way we speak to donors and partners about this work. Now, instead of focusing on ensuring a safe delivery, we speak of the tragedy that doctors, nurses, and patients do not have a way to wash their hands in the clinics. Because people can relate to it, now we speak about protecting frontline healthcare workers and preventing the spread of deadly infectious diseases. Now, our actual work in the clinics has not really changed, but the communication has allowed us to step up the work. For instance, we convene groups of people in the US that work in the healthcare industry to let them know about the situation and how they could help. Individuals, corporations, and foundations have stepped up to fund the work, including the Conrad Hilton Foundation, Robert and Laura Abernathy, and Midmark Corporation. This is interesting. One of our donors established a COVID-19 testing center here in the US and then pledged their profits to help fund the work in the developing world. And this allowed us to have a match for donors in the US. The pandemic has also been a time that we've been able to step up our game in collaboration between our WASH and health sector efforts. In fact, we've already surpassed our goal for providing hand washing stations in all the areas of care. The goal was 800 healthcare facilities, but we've now reached 862. And we've reapplied what we learned during the Ebola crisis in West Africa to address COVID globally. Specifically with Ebola, we learned that the triple combination of our on-the-ground staff, community health workers, and local faith leaders could be extremely effective in providing trusted communications that change people's habits to prevent the spread of the virus. So with COVID, we've used our on-the-ground staff, and we've now trained more than 140,000 community health workers and more than 200,000 faith leaders on the critical messaging to prevent the spread of the disease. So I guess you could say that this horrible pandemic has had a silver lining, and now what we need to do is sustain that effort. Thanks, Tom.
Okay, great. Congratulations, that's a fantastic effort. And very interesting the way you say that you have repackaged your messaging with the advent of COVID in order to make it resonate better and to drive changes on the ground. And how you've managed to bring together WASH and healthcare professionals who speak sometimes different languages and maybe have different priorities and maybe use different messages. But the key being to develop communications that are trusted at the local level so that we can see long-term changes in behavior as a result of the response to this crisis. I'm afraid we have very limited time. I would love to continue this discussion with our panelists, but we've already run over the time allotted. So I would just like to pass this back in a moment to wrap up our session. But before I do that, I would just like to say an enormous thanks to our panelists for holding on to the end. To Dr. Jello from Guinea-Bissau, to Dr. Rakota Risson from Madagascar, to Christia Sala, and to Greg Allgood from World Vision. With that, I would like to pass back to our WASH Chief at UNICEF, Kellyanne Naylor, just to wrap up our webinar. Thank you.
Great. Thank you so much, Tom, and really to all of you for joining us today to launch the Global Progress Report on WASH and healthcare facilities. You know, as we said in the beginning, it's been months of preparation to bring us here today. And I think it's just been absolutely inspiring and really a great opportunity to appreciate all of the representatives here today from governments and organizations that have been sharing your reflections, from Mali to Serbia to the Philippines, WaterAid, Guinea-Bissau, Madagascar, White Ribbon Alliance, World Vision. Thank you all so much for these valuable insights. And I think it goes without saying that a lot of work has gone into bringing this together for today and the conversations that will follow. But we can really reflect already on the data updates that Rick and Maggie presented. I think we can congratulate ourselves and the countries and the global community for the progress that we've made so far, the concrete commitments that have been made, the great examples from early adopter countries. It's clear we are making tangible progress. But we also still have a lot ahead of us, and we can also look at the fact that the situation is still alarming. And I think particularly we've highlighted the situation in the least developed countries, where over half the healthcare facilities lack basic water facilities and 60% have no sanitation services. So we do think that this report can help provide guidance and insights on closing this gap. We must absolutely double down on implementing these recommendations, implementing costed national roadmaps, monitoring and regularly reviewing progress, developing capacities of the health workforce, integrating WASH into regular health sector plans and budgets. We know this is not the first nor the last pandemic that the world has faced. And if we truly want to unlock the opportunities of this specific moment, which is a historic moment when the world is looking forward to building back better, more resilient health systems, we absolutely need to prioritize this issue of WASH in healthcare facilities as part of national plans and strategies. So just to close, maybe it's just so simple as to be obvious, but healthcare workers need a clean environment with proper water, sanitation, and hygiene facilities to provide care safely to people that are in need. I think we've seen today that the cost of inaction or taking no action is great, while addressing this solvable injustice is both cost-effective and doable. So I just wanted to call all of us together today that I hope we can use this information in the report to help us, whether we're working globally, regionally, nationally, subnationally, or even in a healthcare facility itself, to make a difference on this agenda. We all have a role to play, and we must make sure that we see concrete impact on the ground where the impact is the greatest. So let's commit today. Let's count on each of us. From WHO and UNICEF, we will continue to work together with you as part of this movement for collective action. Let's use this as a springboard to accelerate and reach all healthcare facilities with basic WASH access, not in 2030, but well before. Let's do it. So thank you very much, and look forward to continuing this conversation as we take this work forward. Thank you very much, and I wish you all the best for a continuation of your day or an excellent evening in your respective country.